So it's good to have 3, just in case koi consensus karana pade to. So we're going to start the session now. The first presenter today is Mr. Rehman Siddiqi from Aga Khan University Hospital, and he'll be presenting an overview on the posterior segment trauma. Thank you.
Assalamu alaikum, everybody. I'm going to just talk a brief overview of posterior segment trauma and some just basic principles for residents, and then these topics will be dealt in details by the subsequent speakers. Acknowledgements is that a lot of slides and videos are taken from Paul Sullivan's posterior segment disease. This is something that we will come right at the end. This is a posterior segment trauma that we sometimes see and we sometimes don't see, and sometimes even when we see, we don't know what to do. So let's start with the types of trauma. There are various ways that the posterior segment can be affected. You can have a penetrating trauma, you can have a perforating injury, and you can have a blunt trauma. And most of us who are working in tertiary centers see all kind of trauma coming to the clinic. Normally, again, there are various classification. I think Birmingham eye trauma terminology system is easy to understand and use. It's easy to document and communicate, particularly when residents are on call. You want to be sure what they're talking about. So the first and the most important thing is thorough clinical examination. So if a child has some sort of injury, you need to make sure that this is not a laceration instead of an abrasion. So it's important to differentiate. Also, there are some signs that when you examine the patient, you can actually tell the differentiating features. So you see the trauma, hyphema, you know that the trauma is extensive. You need to check the pupil, check vision, and always think that there may be more injury than what you can evaluate in an urgent situation. You can have lens lying at the back of the eye. You can have traumatic retinal detachment. You can a lot of the time ultrasound examination is necessary, and you can have this sort of suprachoroidal kissing choroidals depending on the extent of the posterior segment bleeding. You should also use additional facilities available, such as a CT scan, which can here show an intraocular foreign body. And posterior segment complications of ocular trauma can be a long list. Okay, we're going to cover some of the topics today. It's very extensive. We cannot cover everything in an hour session, but these are the things that you have to look out for. This is a common example of a choroidal rupture we see in the clinic. You can see these concentric lines. Sometimes these would develop complications such as choroidal neovascular membranes that would require treatment, such as this case. It may happen in the long term, not immediately after the trauma. You can have a traumatic full thickness macular hole. I think this will be discussed in subsequent sessions. I think the risk factors to remember is blunt trauma, electric shock, expansile shock waves, laser burns, lightning. The problem is that there is commotio, there is choroidal rupture, there is retinal breaks and dialysis. So it's not just the break that you're dealing with sometimes. And this is just an example of a traumatic macular hole. And the interesting thing is that you rarely see an operculum because it's mostly caused by the expansile forces. And the treatment remains controversial because sometimes they close, but the larger ones usually don't. And visual outcome actually depends on the associated injuries. And I think that, the anatomical results can be good, but the visual outcomes are mostly modest. Then you have traumatic retinal detachments, such as, giant retinal tears, particularly in children. And sometimes they can be very difficult to treat, particularly if they are inferior giant retinal tears, because children would very difficult to get them to posture. But luckily the trauma mostly, you get the traumatic retinal detachment, you get dialysis, and I think we had a long discussion yesterday about how to treat them. Most of us agree that, this is somewhere where all of us will do actually a scleral buckling procedure. The problem is that because unless the child develops some subsequent complications, most of them would present late with retinal detachment, and then there's a remote history of trauma, and then they would have a lot of PVR, and then there's a guarded prognosis because of amblyopia. Sometimes they actually present with a cataract, and then when you do a B scan, you find that there's a closed funnel retinal detachment. So here's an example of a patient seen in, ER. You see a patient with hyphema, you think this may just be a blunt trauma. But if you're seeing somebody with, a hyphema, you really need to check their vision, do the pupillary checkup, because here there can be a much bigger problem at the back of the eye. So, don't assume that this is just a traumatic, hyphema and that's it. Usually there's a problem. Now, the next couple of slides are mainly for residents. So if you see this kind of break or rupture, what you need to do is to really try and clean the vitreous. If there's any vitreous in the wound, use the cutter. You can use the cutter associated with the cataract machine. You don't have to open a vitrectomy pack, but really clean the vitreous before tying up, because sometimes when we end up seeing these patients, they've already had the wound closed and there's a vitreous in the wound, there's a traction, there's a problem. And if you see a wound like this, what you need to do is to apply a 50% rule. So, you divide the laceration into halves and start putting stitches at every half. So what do? You kind of think at, in your mind, try and measure it. So close one half, then close another half, close one half, and this way you will find it's a lot easier to actually get everything right. And another principle I think most of us would remember, but it's ship to shore. So the fragment that is moving or moving away, try and bring it closer to the main thing rather than going away. And you can see that here it's you're applying this right and going to the shore, to the main attached part. And I think this is really a basic principle, but sometimes when you're on call and you're doing this procedure late at night, there's a lot of bleeding, you kind of forget. And another thing is that pull, don't push, and try and get the help of your assistant. So it's really, sometimes it's a tri-manual surgery. So you have got, you're trying to suture, choroid is coming out, and you get somebody to use a spatula to put everything back in place. So just jumping right to the other side, here's a case of trauma. Okay, so 50-odd doctor from interior Sindh, recent onset flashes, history of IRD, PPD done a couple of years ago. Patient had Rosso, NPL vision in one eye, and this is the other eye. Yeah, and he had remote history of trauma for which he received the vitrectomy. So any resident, what's happening here? So it's a talk about trauma, and you see all these white lesion at the back. Come on, somebody can shout from the back. Okay, everybody's shining up. Here is the FFA. Yeah, these lesions are dark at the start, they're lighting up at the end, multiple lesions. Yes, very good. I hear somebody saying something, and you can see the OCT here. And you can see this area, the RP is separated from Brooks membrane, and there are accumulations. Yeah? And what are these accumulations? This is the other eye, yeah? Yep, so it's sympathetic ophthalmia. So you really have to think about these things when you're dealing with trauma. And this is again, if you look at the histopathology of Talon-Fuchs nodules, you can see that these nodules are actually very similar. You see here? Sorry, यहाँ पे. ठीक है, this is the RP that is raised, it's not coming as nicely, and this is the Brooks membrane, these are the accumulation. And you see that it's very similar. And we have published this case as well. So, obviously you need to do immunosuppression, and we can have a long discussion about role of enucleation of the other eye when the second eye present with sympathetic ophthalmia. Now, just a slide of the first patient that I showed, right at the start. Okay? What is this trauma that is presenting? Again, this is a trauma that sometimes we see and sometimes we don't see, and sometimes when we see, we kind of don't think about it. And that's the reason I just put up this slide to highlight. Yes, yeah. And I think in our society, the problem is that you don't want to make that diagnosis. Because, this is a shaken baby syndrome, and, in a small baby. And even when you see it, you start going in one direction and the other direction. And I think the problem is, even when you make a diagnosis, what do you do, really? So anyway, the take-home message is examine carefully. You need to do sequential examination. You need to do a lot of ancillary testing, document the extent of injury at the beginning, because a lot of the time these patients will see you at the initial trauma, and then they go to other doctors and they will never mention the extent of injury they had at the time, and it would appear that the job that you have done is poorly executed. But if you have things documented nicely, ultrasound, imaging and everything, that would help. And really counsel family about multiple surgeries, and the eye may or may not be lost and all. So I think that's very important. Thank you so much.
Thank you very much, Mr. Rehman Siddiqi. Any questions from the audience? Or anybody from the chair who wants to contribute anything? Yeah, mic, दे सकते हैं, please? Sir, आ रहे उधर से.
Since we also, I'm expecting some residents are here as well. What suture do you use for repair of the scleral tear?
Well, I think the scleral tear has to be repaired with a suture that would last much longer. So I wouldn't use absorbable sutures to repair the scleral wound.
The reason I ask this question is I have very good experience with, I think, when we are talking about a posterior rupture and British and retinal prolapse, I use a 10-0, and everybody gets surprised. 10-0, it won't hold the wound, and it won't stay, and there's a likelihood that it will break and there will be a wound prolapse. I have never seen it.
You use 10-0 nylon?
I use 10-0 nylon,
okay.
And it meticulously we are able to suture the scleral rupture with no prolapse of the vitreous or the retina. So it's just my personal experience. I thought I would just share it with you.
Thank you very much. I think the point really is the suture really has to be non-absorbable, because you can't trust that, and sometimes more importantly, because when we actually go in the eye later with a problem, the last thing you want is to actually go back and repair the primary wound. So that wound has to be tight so we can put trocar and Kaluna to repair retinal detachment. So thank you very much for raising that point.
Thank you very much. Any more questions? Mr. Siddiqi mentioned about a very good book from Paul Sullivan. आप लोग सब उसे डाउनलोड कर सकते हैं. It's free. It's on the Apple bookstore. And the concepts आप जो develop करेंगे, it will be very good. Secondly, I think in Paul Sullivan book, he's mentioned if the trauma is anterior sclera, where the blood supply is good, you can even use the vicryl. But more posteriorly, where there is a less blood supply, you need long-lasting sutures. Yeah, I use as well, sir. Yeah. दो मैं अब करना छोड़ दिए हैं traumas, लेकिन मेरा ख्याल है हमारे trainees are expert now with the trauma. So our next speaker is Mr. Amer Awan from Shifa International. He'll be presenting on the intraocular foreign bodies.
Thank you very much. Assalamu alaikum. That's okay. Can I have my presentation there, please? Okay, so I'm going to talk about intraocular foreign bodies, and they are challenging, and their visual outcome can be very variable. And sometimes it's really important to look at the history, because from the history you get the clue about that what exactly happened and would there be any foreign body or not. And sometimes the foreign bodies can be hiding in the ciliary body region, so it's really important to look at the history. So it can happen at the work, it can happen at your parties, home, or even unexpectedly, like bomb blast injuries can happen. So clinical history is really important, physical examination, and imaging is really helpful to give you a clue that where can be the foreign body. And early management is really important in such cases. So if you look at the epidemiology, 20,000 to 68,000 serious visual threatening ocular injuries occur in the United States every year. And intraocular foreign bodies are found in 8% to 25% of all open globe injuries. So most intraocular foreign bodies, patients are male because of their nature of work, and they are usually young, between 21 to 40 years of age. And common location of injury is the workplace. So already mentioned history, clinical examination, and imaging. So it's really important to know about what sort of a foreign body it is, and that again you get the clue from the history. So it is metallic, which are by far the most common, followed by organic one. And glass intraocular foreign bodies, I'll show some video as well, account for 6 to 9% of all intraocular foreign bodies, and they can be observed, and because they are not going to cause much damage. But metallic foreign bodies are really nasty. If they are going to stay over, they are going to damage the retina, and the patient will lose the vision. So usually they are posteriorly located, most commonly in the vitreous cavity, but it depends with how forceful they were. They can hit the retina, or sometimes embedded within the choroid, or sometimes even they can, due to double perforation, they can just pass through the eye. And when you're looking at the foreign bodies and anteriorly, it's really important to look closely for them. They might be in anterior chamber in the angle, and you can easily miss it if you overlook it. So that's the unfortunate person who was basically a truck driver, and his truck had some problem. He was just standing by the truck, and something hit forcibly to his eye. And when I looked at in the clinic, I couldn't see anything. I would see like a conjunctival, subconjunctival hemorrhage there in that area. Fundus examination, I could see only a black sort of thing, which I'll show shortly. But when I opened the conch, I could see something like that. It's here. I thought, okay. So that was the thing. Basically, it was a stone, hit him, ruptured the medial rectus, so I had to suture up that area, and it was so posterior I couldn't suture completely. So I did it up till as much as possible and removed the foreign body. And that was a frontal view. So here the retina was detached as well. So what I did fluid exchange, did laser as much as possible, and I put silicone oil. But next day when I saw, half of the silicone oil was out, because in this case even air, nothing could stop over there, because significant amount of the wound was open. But we were lucky. Retina remained attached later, and I think still I have to remove. This was the area. So even posterior perforation, even you don't, their fibrosis will happen, they will close. So what a point I want to make is, so they get closed. So you try to suture from anterior to posterior as much as possible, and now plan is to remove the oil in this case, and the retina is attached. That's another female teacher who was teaching in school in I think Gilgit or Chitral, and suddenly something hit her eye. And what actually happened, somebody was doing shooting, and that's basically a pellet that landed in our eye, and we removed that by giving this clear. So these become more tricky because they're round. Removal becomes tricky in that, and even though your clear incision would be the larger one to remove it. So initial treatment is very important. So primary repair you need to do, and you need to do immediate referral to your vitreoretinal colleagues about that. And these are the cases, especially the metallic one or any organic one, endophthalmitis risk will be very high. So if you leave it, you just start on the drops and the things, they are going to develop endophthalmitis. Counseling is really important. You need to discuss about, as Rehman rightly pointed out, sympathetic ophthalmitis is one of the risks to the other eye, so they need to know about it. And the timing of surgery is really important. So primary repair immediately as early as possible, and then the referral, and depending on the circumstances of the eye, further you can proceed accordingly. Anesthesia, usually these are the cases you'd want to do general anesthesia. Try not to use local anesthesia because their sclera is ruptured, anything when you're managing initially, so better thing. And you can get surprises, so ideally it's better to go for general anesthesia. Entry wound needs to be closed properly, so that's really important. If there is a cataract, you need to manage it so that you can have a better view. So this is the case in which basically during the party LED light was ruptured, and that was a filament that went into the eye. It's a linear large filament that was there. I'm inducing the, sorry. So I'm inducing the PVD, and then once you remove the vitreous completely, you want to make sure there is no vitreous around that. So I'm teasing it out, it's impacted deeply, and take it out from that area. Sometimes bleeding can happen as well, so you can increase the infusion pressure to avoid that bleeding, and you can remove it gently. And again, it's important thing is that you want to make sure that doesn't land on your optic nerve or macula. So to prevent it, sometimes you can use PFCL to avoid that. In this case, I'm not using it, but I'm very careful to lift it up. So once you remove it, you leave it, you have to remove it through some scleral incision. So in this case, what I did, I just removed my trocar. It was 27 gauge, and slightly enlarge it. And once aligning it, lucky thing is because it's a linear one, so it could easily come out of so here it's landing over the retina. And once I aligned it, I'm going to remove through the incision, and then fluid exchange laser and gas was used in this case. So that's another case in which you can see area where the damage is suggesting. So here the cataract has been already done, posterior capsule was ruptured because the foreign body is gone, and here the foreign body is floating over in the vitreous cavity. There are small one as well, but this one is the large one. And after inducing the PVD, so always it's important, try to do as much as vitreous removal, and posterior highlight phase detachment is really important in such cases. So once do that, you hold it with the forceps, and you can remove the foreign body. So I think better thing what I would suggest is to use the PFCL, because in this case it came up to the macula as well, and it could be possible that it could just land over the fovea as well, so you can use it. So what you can do is sometimes just a cutter can be used at. So here I sucked with the cutter, brought it forward and using the forceps and removed it and finished up the case. So that's another case. So here basically it's 25 gauge vitrectomy, which I am doing. So removing the vitreous hemorrhage there. And sometimes you're not seeing, so you need to indent it to identify where the foreign body is. And that's where basically you get clue from imaging. Imaging gives you the clue that there must be something. So here I'm indenting it, and foreign body was basically impacted there in that area. So you need to mobilize it from that area and remove it. And the reason being is because if you keep it in metallic one, they are going to cause retinal toxicity and there will be damage. So shortly as the hemorrhage will get clear, you would see the foreign body there. So just keep watching that area. So once it's done, so you remove it and you bring it forward, and you can remove it from the corneal incision, which you have already given in this case. So next case is basically he had a bomb blast injury, I think 12 years ago. Primary repair was done, cataract was even done, but nobody noticed that this large amount of glass foreign body was there. So when the retina detached, the patient was referred to me, and first thing I noticed that there is a large glass foreign body there, and the break actually happened besides that area where there is a large foreign body, and it was quite huge. So shortly you would see that how big scleral incision I'm going to give. So again, same thing, you have to complete your vitrectomy. You release the traction around that area. So here I'm opening up the conch, and once open up the conch, it's very important when you're removing the foreign body, make a large incision than as you're expecting, because you don't want to drop it in when you're taking it out. So here I'm using the forceps and bringing it out from that area. So once it's done, I sutured it up, and we did fluid exchange and gas to C2F6 gas was used, and he had a very good prognosis. Vision improved to 6/9. So that's another interesting case, who basically was sleeping and somebody attacked him. He wasn't sure what exactly happened, what thing hit the eye, And he was a very odd character. So his wife was a nurse in our hospital, so she brought. So it was very dense hemorrhage. Vision was PL plus minus, and very dense. And shortly you would start seeing what actually. So retina was detached. There was a vitreous hemorrhage there, and I was clearing carefully because the retina was detached as well. And suddenly you start seeing some metallic thing coming up. So I thought, okay, maybe something saying, look how large. And that was basically a syringe needle. So even looking at externally, I didn't expect that something like this has happened to the person. So I'm gently pulling, and still I'm not sure which part needle is, which part is other thing is. So, and then other thing you have to think that how we are going to take it out. It's a phakic patient. Phakic patient, I'm not remembering correctly. We'll see shortly that pattern. So now I will align. No, it's not phakic. It's yeah. So I have removed the cataract in this case. So what I'm doing is I'm removing it from, given the incision there, because it was bent over there. So I removed from that area. So how large was this? So huge. And he did well. I think vision was counter finger later. So that's basically what thing happens if you leave the foreign body. So this is the case in which the patient had some trauma long time ago. Even the doctor did the cataract surgery, but they didn't realize that any foreign body is there. And this patient, all thing was pigmented. If you look at the iris color, that was looking different. Even the retina color was different. So these are the cases. Basically, surgery was done for inflammation purposes to settle it, because vision-wise things are not going to get better. So it was a large foreign body which was removed in this case. So intraocular foreign body cases are complex and require careful history, examination, and imaging. It's really important to do imaging, and you need to do the primary repair properly, and please do timely refer. And again, important thing is counseling in these cases. Thank you very much.
Thank you very much, Dr. Amer Awan. Very interesting and very good videos. Before anybody can ask the question, may I ask a few questions? The forceps you're still using is 27 gauge. That's amazing. 25, okay. Okay. Yeah. Fine. Thank you very much. Any questions?
Excellent presentation, Amer. I think with the advent of these trocars, 23, 25 and 27 gauge, it is quite handy to keep 20 gauge foreign body forceps in theater, especially for these large foreign bodies. And the other thing I think we need to highlight is that the infusion that we use during removal, the vitrectomy for foreign body, it should have a cocktail of antibiotics. We use vancomycin, ceftazidime, and amphotericin B in the infusion, because you don't know what germs they are carrying.
Thank you very much. Any more questions from the chair? Anything, co-chair? Do you want to ask anything?
I like to ask a question. In that case, in which there was trauma, the patient who had syringe in the eye. So was he brought in emergency? Like the retina seemed fibrosed.
Came immediately, I believe in 2-3 days.
Right.
But it was so extensive damage. He was a very odd character. History-wise, he wasn't sure what is the fight, but what he was telling. And unfortunately, his wife took divorce later as well. So after 1 year when he came back, so yes, I don't know what was happening. There were a lot of psychology.
She was a nurse?
He was a nurse. So it's quite evident. Thank you very much.
Any more questions? I can see we've got few fellows here from the VR and few residents here. Can I ask you a few very basic questions, sir, if you don't mind? How would you do CT scan on all trauma cases?
Yes, I would definitely.
This is my practice as well, sir.
Exact localization. If you're going in, it's always better to have CT.
And basically, one of the reason I asked you was we had one patient and we removed the foreign body, जो कि हमें नजर आ रही थी. And later on, the patient still developed the sidrosis. And we ended up doing the CT, and there was a ciliary body make, and there was another foreign body sitting there. So I think spending 2,000-3,000 rupees is a good investment. Plain X-ray, yes. Lekin sir, glass wouldn't show. So my standard is, yes, straight away across the road, Fuji Foundation, CT scan, when they come to me. How soon would you go in, sir? If the patient comes to you on Saturday afternoon, would you open up theaters, or would you do on
Primary repair or
intraocular foreign bodies, metallic foreign bodies?
repair is done already or not?
It comes to you as a VR, sir, intraocular foreign body usually.
Yeah, if the primary repair is done, I would look at the situation. If there is no inflammation or anything, I would rather plan to have it in my theater session. So weekday I would, because nursing everything would be there, I will do there. But if it's a primary repair I have to do, then I would go immediately, because primary repair I won't delay it. As we get it, we try to get it done as quickly as possible. If patient's NPO is there, so I will go in and do the surgery.
One of the videos you showed was with the sidrosis. When would you not operate? We get a patient with sidrosis, and it's light perception vision. And usually the metallic body you cannot see. It's gone by the time you've gone.
I think it also depends on your visibility as well, because in this case, although the cornea was quite pigmented, but there was some visibility, and patient was having inflamed eye as well. So I discussed, yes, we can leave it, but your inflammation will remain like as such, so we can remove it. Because vision was PL negative in this case. There wasn't any, it was just because of the pain and inflammation. I did
so basically to prevent the painful eye.
Yes, that was the purpose, but yeah.
And I know, sir, आपने कहा कि you use the infusion के अंदर आप antibiotics use करते हैं. Would you give antibiotic as intravitreal at the end?
Intravitreal, if it depends on how the foreign body is. If I'm suspecting it can lead to endophthalmitis, yes, I would use it, but not in every case. I use intravitreal antibiotic. Not in every case. Subconjunctival I gave, and later orally I do give antibiotics.
Thank you very much. So we'll move on to the next presenter. Our next presenter is Dr. Shehzad Saeed from Islamabad, and he is going to be presenting on the traumatic optic neuropathy.
Yes, slide change.
ये मेरी लगी नहीं। Bismillahirrahmanirrahim. Before I start, I take this opportunity to appreciate Dr. Amer Awan, the way he has been working on the PVRS scientific program for the last 4 or 5 months, and the way he has conducted it in the last 3 days is amazing, because I haven't seen a better outcome regarding the quality of scientific papers as well as attendance in any PVRS sessions for a long time. So we must appreciate the efforts. मैंने सुबह वैसे कोशिश की, I was too exhausted, I tried to skip the paper, लेकिन वो he simply refused. He said nothing unprofessional will be accepted. So I even appreciate that. So I'll be talking on traumatic optic neuropathy. My talk would be very basic, because the theme of our conference is comprehensive ophthalmology for general ophthalmologists and postgraduate trainees. Whenever trauma occurs, trauma is something, very debilitating, because you are perfectly fine and few seconds later the whole world changes. I had a very bad experience in Bali during the conference, and I can understand when trauma happens, everything changes. Everything changes. The most beautiful places in the world feel like hell. So at one point of time you are seeing everything, and suddenly you go blind for whatever reasons. Why traumatic optic neuropathy? The eye seems fine, but the patient cannot see. So we need to investigate from anterior till the posterior most end to find out the cause why the patient is not seeing, because the first thing that comes to us, if everything is fine except for the pupillary reaction, if at all that is abnormal, then the patient might be malingering. So we have to be very, very meticulous in our clinical examination and investigations to find out the cause of that sudden decreased vision. So the cause obviously is a trauma which may be blunt, which may, penetrating, direct or indirect. The indirect is usually caused by rapid acceleration and deceleration. So whenever, history is very important, because these are the clues which will give you an idea what you need to look for during your clinical examination and the investigations which you plan. There may be compression, shearing and ischemia. Compression causes, the optic nerve is usually swollen in the initial phase, so compression causes pressure on it and causes the damage. It is important to find that out, because we always say you have to detect early and treat early. So what to treat in traumatic optic neuropathy? Compression is one of the things which you need to treat early. And obviously if there is inflammation, you have to start the medications as soon as possible. Shearing, if that has occurred, then there is not much we can do, but obviously we have to follow up the case. Symptoms, sudden visual loss, signs, reduced visual acuity as well as the color vision, visual field defects. I'll talk about what type of visual field defects we can have. Relative, depending on the extent of the injury, it may be relative or it may be afferent pupillary defect. Visual field defects depend on the part of the nerve that is damaged. So there may be central scotoma, altitudinal defects, nasal or temporal defects, generalized constriction or sectoral defects. So if we are suspecting, we must go for a visual field scan to find out, give us a clue what type of injury has happened. The diagnosis, history, like I said, is very important. Clinical examination from the anterior segment up to the back of the eye. Imaging, CT scan, MRI, and for us ophthalmologists, OCT. The findings of the OCT I'll elaborate in the coming slides, and visual evoked potential. I'm more interested in visual evoked potential because recently I've started working on the handheld ERG and VEP, and definitely it has its role in identifying certain diseases which the other investigations don't give the exact clue. So in traumatic optic neuropathy, visual evoked potential may show increased latency, which indicates that the transmission of visual information along the optic nerve is slower than normal. It is working, but it is slower than normal. A reduced amplitude indicates fewer optic nerve fibers conducting signals effectively. So increased latency as well as reduced amplitude, one may be there or both might be there. And absent response, if there is no response on VP, that indicates that the visual prognosis is very poor. Like I said, the prognosis, why we need to do the VP? To check the prognosis, depending on the level of decrease in the amplitude or the total, if it is totally absent. Monitoring. The best method of monitoring is obviously visual acuity, the patient and the color vision in optic nerve diseases. But yes, this gives you a quantitative analysis of whether the nerve is getting better with your treatment or as the time passes, usually it heals itself. So that can quantitatively be measured with VEP. And differential diagnosis, we can differentiate other causes of like the retinal disorders, lesions in the visual cortex, because there are different VEP patterns in each one of them. OCT, the easiest thing that we can do is get an OCT done, but there is a catch in the OCT. The acute phase shows something very different and the chronic phase shows something really different. In the acute phase, there is swelling of the optic nerve. And in the chronic phase, the retinal nerve fiber layers, they start thinning down. So the level of thinning, that again points out to how much extent of damage there is and what the actual prognosis would be. Ganglion cell complex atrophy is also seen, And optic disc changes like optic disc edema and pallor. Pallor obviously is not an OCT, but this is these two things. You always remember, don't judge the OCT on its own. You have to see clinically the disc as well as OCT if you have the print available with you. Because sometimes the OCT may be done incorrectly. It may give you a retinal nerve fiber layer thinning because it was not done actually, or if the patient has cataract and the SSI is less than 5, again it may show thinning of the retinal nerve fiber, which actually might be normal. So again, on the OCT, we can diagnose, we can monitor, and obviously the more the damage to the retinal nerve fiber layer, the the prognosis would be from bad to worse. Management. Unfortunately, there is not much we can do, but depending if we can find out the cause of what the damage that was done, the cause of that, if there is, the vision is good, the pupillary reaction is slightly sluggish but not absent, we can observe. But if we feel that there is an inflammatory optic nerve swelling, we need to start the steroids as early as possible. Any delay in that would lead to a very bad prognosis. Surgery, as I mentioned earlier, for optic nerve decompression, we need to go for surgery, and that should be done again as early as possible, because any time lost during that compression would lead to permanent damage. And supportive care, if obviously the patient, like I said, is under severe mental and physical trauma, so he needs the supportive care like rehabilitation, visual aids, and counseling. Prognosis depends from case to case basis. So every case has to be assessed separately. We cannot gauge that this is the format I would follow for every case, because depending on the type of trauma, whether it was blunt, penetrating, or acceleration, deceleration, depending on the clinical examination, the extent of damage which we can find out with the clinical examination supported by OCT or VEP, we need to modify and plan our treatment accordingly for every individual case. Thank you.
Thank you very much, Dr. Shehzad. Any questions from the audience here?
For traumatic optic neuropathy, like in central retinal artery occlusion, we give 3 intravenous steroids followed by 11 days. In this, what regime? Well, everybody has their own preferences, but oral steroids do work. So you don't need to give 3 days of intravenous. So oral steroids would work. And you have to give full dose.
Please, sir.
Excellent presentation by Dr. Shehzad. Just to add on, nothing to comment. In few cases we have seen in Lahore that everything was normal. CT, MRI, OCT, everything was normal. So when we did imaging of the optic canal, so there was fracture of the optic canal. So that led to NPL, because there was no compression, but there was no swelling. So that fracture probably cut the optic nerve. So we must keep in mind when we go for investigation, so we have to advise the CT, when to advise CT scan or MRI, we have to tell them that to look at the optic canal, for fracture of the optic canal.
VP कहाँ पे available है इस्लामाबाद पिंडी में? I've never requested. AFIU? जी सर.
2 months. So we have started using it. वो उधर ही available है.
AFIU?
नहीं मैं at Islamabad आया सर.
Oh अच्छा. Perfect. Perfect. अभी ट्रायल चल रहा है सर.
ये एक्चुअली 2 चीज़ें, ये अभी हैंड हेल्ड आई थी, तो मुझे एक दफ़ा जो मेरे उस्ताद हैं जनरल मज़र, उन्होंने कहा था जिस चीज़ की समझ ना आए ना वो मशीन ख़रीद लें. तो मैंने पहले कॉर्नियल टोपोग्राफी ली, क्योंकि उसकी समझ नहीं आती थी सीधी साइड कौन सी है, तो वो अब समझ आनी शुरू होगी. और वीपी जब मैंने ली तो मेरा हमेशा से ये ख्याल था शायद एक यूजलेस चीज़ है, क्योंकि जो वीपी और ईआरजी और ईओजी की जो मशीन्स थी उसमें करना भी पेशेंट के लिए भी सज़ा थी और करने वाले के लिए भी सज़ा थी। इसमें इट इज़ हैंड हेल्ड, बड़े आराम से आप बेशक पेशेंट को बिठाएं या लेटाएं, इवन बच्चों में भी प्रॉब्लम नहीं है, वो ब्लिंक भी कर रहा है, थोड़ी बहुत मूवमेंट भी है, तो वो सेंटरिंग बच्चों में आई ऑलवेज डू इट इन डायलेटेड प्यूपिल, तो वो उसमें इसके रिजल्ट्स अब मुझे जो चूँकि उसकी समझ आनी शुरू होगी, इट हैज़ इट्स रोल, इट डेफिनेटली हैज़ इट्स रोल, बिकॉज दिस इज़ दी ओनली इन्वेस्टिगेशन जो आपको उसकी फिजियोलॉजिकल वैल्यू बताएगी स्ट्रक्चर्स की।
कॉस्ट कितनी पेशेंट को पड़ेगी सर?
सर उसमें अभी जो हम कर रहे हैं, वी आर डूइंग ईआरजी इन 15,000 एंड वीपी इन 5,000, क्योंकि ईआरजी में वो डिस्पोजेबल इसके वो लगते हैं,
प्रोब्स लग रहे हैं। यस
Dr. Shehzad has done a brilliant thing. So because previously we all were struggling, AFIO we were sending, but they were not getting time there.
Backlog काफी उनका था.
Not like that. So it's easier, and you can just call and immediately it's get done. So it's very good.
Sorry, the make of this.
किसी अमेरिकन कंपनी है सर, और ये यहाँ पर भी आज उन्होंने रखी हुई है।
अच्छा।
इधर स्टॉल पे।
LKC
कंपनी का नाम है सर।
Okay.
किसने रखी है? वेंडर कौन है पाकिस्तान में?
सर ये मेडिक्विप्स वालों।
Thank you very much. So we'll move forward, and the next topic is traumatic endophthalmitis by Dr. Muhammad Tariq Khan Marwat. So please, thank you.
Bismillahirrahmanirrahim. Well, ocular trauma is one of the major challenges for ophthalmologists. We all know about it. I was just remembering one of our studies that we conducted long before in our public sector hospital. And I remember more than 70% of our inpatients were the victims of ocular trauma. So you can just imagine how important this is to focus this very important pathology. So traumatic endophthalmitis is one of the challenging entities that we confront in our settings. Basically, this is the infection of anterior and posterior segments of the eye after an open globe injury. And it was just mentioned in the previous presentation that after open globe injury, the chance of endophthalmitis is from 7 to 25%, which is quite significant. And 33% of all the infectious endophthalmitis, they are basically traumatic endophthalmitis. And after open globe injury with intraocular foreign body, the chance of endophthalmitis goes up to more than 40%. About the etiology and the causative organisms, 60% of the traumatic endophthalmitis cases are caused by the gram-positive organisms, the staphylococcus, the bacillus, the streptococcus, and enterococcus. About 10% they are caused by the gram-negative, and the 20% cases remaining amongst the bacterial cause are the polymicrobial. Rarely we can have fungal endophthalmitis. The cause may be Candida, Aspergillus, and Fusarium. And again, if there is a setting of intraocular foreign body, the cause may be Bacillus cereus, which is again a very noxious type of organism. The risk factors after open globe injury for getting traumatic endophthalmitis include delayed primary repair of open globe injury. So the more you delay it, the more is the chance in case of open globe that this eye will become a case of endophthalmitis. Retained intraocular foreign body contaminated and dirty wound, ruptured lens capsule, large wound size, vitreous prolapse, and old age. These are the risk factors for traumatic endophthalmitis. How to diagnose it? I mean, early diagnosis is definitely important. And in this scenario, probably B scan plays a very important role. Of course, we have to be more careful in case of open globe injury while doing B scan. But it's important to evaluate vitreous opacities, intraocular foreign bodies, and the status of the retina and the choroid. And especially if you are planning pars plana vitrectomy, in such cases, it's crucial to go for a B scan. And better to do it by your own self rather than by a technician. CT scan and plain X-ray we just discussed previously. It evaluates for intraocular foreign body if it is suspicious, and it's less costly relatively, and very important informations can be gathered. Culture samples should be obtained from the wound, from the vitreous, and from the anterior chamber, and slides should be stained with Gram, Gemza, and KOH stain. KOH is specific for fungal infections. And media inoculation on blood agar, chocolate agar, and Sabouraud's medium. They are also very important so as to get the culture and sensitivity. But even in best settings, only 70% of the vitreous cultures yield positive results. What about the prophylaxis after penetrating trauma? The clinical evidence of any prophylactic measure is not established by a randomized trial. So they are not established points, but intravitreal antibiotics can save the eye after open globe injury from getting traumatic endophthalmitis. Some authorities advocate intravitreal antibiotics in all cases of penetrating trauma, especially with intraocular foreign bodies, while the others recommend only in the presence of risk factors. 2 of the 3 risk factors are sufficient to decide for the intravitreal antibiotics, like dirty wound, lens breach, and delay in closure over 24 hours. If 2 of these 3 risk factors are there, studies have shown that intravitreal antibiotics can save this eye from endophthalmitis. The role of systemic antibiotics is controversial, but some studies have shown that intravenous cefazolin and followed by oral moxifloxacin, they can help as a prophylaxis in penetrating traumas. Treatment considerations, while we are planning treatment for such cases, very important is to take expedited vitreous biopsy and then do primary repair. And if possible, while doing primary repair, also remove the intraocular foreign body. In severe cases, early and complete vitrectomy should strongly be considered. Remember, this is the answer to the treatment of traumatic endophthalmitis, early and complete vitrectomy. And some authorities also advocate therapeutic vitrectomy in all cases, while others suggest that vitrectomy only should be performed in those cases who do not respond after 48 hours of initial treatment or even with the intravitreal antibiotics. Empiric medical therapy includes intravitreal vancomycin and ceftazidime, is advocated by the endophthalmitis vitrectomy study. But we do not follow the endophthalmitis vitrectomy study in full sense in these cases because these are traumatic cases, and endophthalmitis vitrectomy study was conducted on post-cataract surgery endophthalmitis cases. So if PPV is performed, intravitreal antibiotics still should be given at the end of the surgery, and also systemic antibiotics should be considered. In special cases caused by Bacillus or Staphylococcus, intravitreal clindamycin and amikacin and also the gentamicin, they have proved to be more efficacious in comparison to the conventional Vanco and ceftazidime. And if we are suspecting or we are having a proof of fungal infection, intravitreal amphotericin B and intravenous fluconazole or voriconazole are recommended. Topical antibiotics, some people have shown that they are beneficial. Systemic antibiotics are usually inadequate and insufficient if they are used as monotherapy. And but nowadays we have very efficacious fourth generation fluoroquinolones. So they have shown to have a better penetration in such cases, and they may be beneficial in some of these traumatic endophthalmitis cases. The role of corticosteroids is again important. The goal is to minimize ocular damage from the host inflammatory response to the infection. Intravitreal steroids have shown to be useful in some cases regarding visual acuity betterment, but in other cases they are not very useful or even worsen the visual acuity. So better to individualize the cases while deciding for steroids in endophthalmitis cases. And it should be avoided in fungal infection when fungal infection is suspected. Regarding surgery, pars plana vitrectomy is often the mainstay treatment. This is another topic which special measures should be adopted while dealing with such cases, while doing vitrectomy in such cases. But if an urgent vitrectomy cannot be performed, then definitely intravitreal antibiotics should be considered to buy time. Emergent removal of intraocular foreign body is important. Intravitreal steroids may be considered once the infection is getting controlled. Intravitreal amphotericin or voriconazole if fungal infection is suspected. Intravitreal steroids may not be recommended in fungal infections, as we just said. Daily follow-up until marked improvement is important. If no improvement within 2 days, intravitreal antibiotics. There is no hard and fast rule that only 3 intravitreal antibiotics injections should be given. It all depends on how the things go on and whether the infection is controlled with the intravitreal antibiotics initially or not. And you can change from one to another as well. Vitreous inflammation and debris may initially worsen before improving. Tractional bands may form, especially if a limited vitrectomy was performed initially due to media opacity. And secondary procedures are common. This is very important to talk to the patient, to counsel the patient about the possible secondary procedures. And these procedures may address retinal detachment, PVR, PVDs, choroidal detachment, and cataracts. In case of corneal opacification, sometimes combined penetrating keratoplasty or temporary keratoplasty or endoscopic vitrectomy may be the options. We see a lot of complications related to the traumatic endophthalmitis cases, including vitreous hemorrhage, recurrent endophthalmitis, retinal tears, retinal detachments, drug-induced retinal toxicity, cataracts, secondary glaucomas, and phthisis. The prognosis is unfortunately not very good. Prognosis usually depends on the virulence of the infecting organisms, the presence of the intraocular foreign body, the presence of retinal detachment, timing of the treatment, presenting visual acuity, and extent of the initial injury. Primary prevention, like in all other diseases, is important. And if we come across a case of open globe injury, expedited closure of the open globe wound is one of the important steps regarding primary prevention. Systemic antibiotics, removal of foreign bodies, and intravitreal antibiotics may help in saving the eye from endophthalmitis. In conclusion, open globe injuries are common ocular emergencies. Post-traumatic endophthalmitis is an uncommon complication, often has a poor visual outcome. Prophylactic strategies to prevent endophthalmitis are non-uniform across practices. So there is a need of large multi-center randomized control trials in this regard. We are still dependent on many aspects of the study, the endophthalmitis vitrectomy study, which was conducted about 30 years back. So I think there is a dire need of new randomized clinical trials to be conducted in this regard. Earlier presentation and treatment are significantly associated with better outcomes, and an early and complete vitrectomy can save many eyes. Thank you.
Sir, thank you very much for a comprehensive talk. Any questions? Ahmed, how's the health and safety regulation in Cairo? Do you see the same number of trauma cases in Cairo, or?
Yeah, we see a lot of trauma.
Yeah, same here.
We see a lot of trauma. I'm working in a university setting. We have a lot of trauma cases. Yes, all cases. Rupture globe, traumatic endophthalmitis, foreign bodies.
What I can tell you is in the UK, when the trainees, they go through their training program, they have to do 2 work-based assessments on trauma. And during those 5 years, they struggle to get the work-based assessment signed off. So there's no trauma
there. They can
there.
come to Egypt.
I know they can come to Egypt.
Thousands of cases, yeah.
The health and safety regulations are very good in the Western world. Yes. Unfortunately, we see a lot of traumas here. And one more question, Irfan. Very nice talk by Dr. Shehzad on the optic neuropathy. कोई चीज़ कर रहे हो in terms of the regenerative medicine on the optic neuropathies?
Thank you, Dr. Amjad. Very good question. Actually, what we are observing through, as far as regenerative is concerned, that extent of trauma actually matters a lot. Early representation, if you get a patient after injury of a history of like 48 hours or 72 hours, and on investigations there's no avulsion, there's no practical fracture of optic nerve canal, and anatomically it's all intact. And if you apply subtenon exosomes, the extent of inflammation reduces, and toxic and traumatic optic neuropathy to some extent is in a very, it has a good response as far as regenerative is concerned. But if there is a traumatic avulsion, or if there's a optic nerve damage, so in that case,
it's not a good response.
It's not a good response.
Thank you very much, Irfan. Anything else from the chairs? Do you want to contribute anything?
Yes.
Ji? Acha, there was one question in terms of the orbital decompression. Is there any services around? I know in our hospital, the orbital team, they are doing the orbital decompression. But I think your question might be the optic canal trauma ke andar jo decompression. I don't know if the neurosurgeons are doing it.
Sir, bas agle ka time.
Okay.
Madam.
Sir, सबसे बड़ा काम है सर, रेटिना क्या कर रहे हैं
सर? बस मैडम कंक्लूड कर दें, फिर हम आपको आपके हवाले कर देंगे.
Before we conclude, I'm sorry, Dr. Farah, we would like to request Dr. Shehzad to come on the front, and Dr. Farah, we've got a shield to honor Dr. Shehzad. So Dr. Farah, if you kindly present this to Dr. Shehzad. And we've got one more shield. Dr. Farah, can I request you to stay on the stage? So the second one is for Dr. Tariq Marwat. And finally, can I request all the presenters to come onto the stage for a quick photo? Thank you. Thank you very much, sir. Over to you, sir.
Concluding remarks.
Itna pressure tha Dr. Farah कि I forgot. I'm really sorry. So the final concluding remarks from Dr. Farah. Thank you.
So I'd like to thank all the presenters for such comprehensive presentations on ocular trauma. I'd like to thank Dr. Shehzad and Dr. Amer for arranging such a comprehensive session. So I think in our setup, we see a lot of trauma because of the very preventable causes. And as a society, I think we need to come to a conclusion that what should be done on the government level to increase the awareness, and because much of the trauma in our setup is because of the lack of the safety measures, which is easily preventable. Thank you very much.